So we can start. Dr. Vikram?
Okay, so I need to introduce.
Yes.
Good evening, everyone. Am I audible?
Yes, yes.
Yeah. So, good evening, everyone. It is our pleasure to start the uh, bi-weekly sessions for intervention neurology subsection. This is our first presentation in the series, and the presenter today is Piyush Oja. He is a senior neurointervention guy working in Delhi, and he'll be discussing today about DSA and how to read anatomy on DSA, which I believe is a very necessary thing for all neurologists to learn on their own. As we know that neurointervention is very rapidly progressing, the indications of the procedure has been rapidly progressing, and the availability of procedure is also quite easy nowadays. So if everyone learn how to interpret them, it will give everyone a very good idea about the uh, entity, about the procedure. So without wasting too much of time, I would like Dr. Piyush to start with his presentation. Thank you.
Okay, thank you. Thank you so much, sir, for the kind introduction. Can I share my screen now?
Yes, yes. Please.
Yeah. Good evening, everyone. First of all, thank you so much to the Indian Academy of Neurology and to Dr. Vikram, sir, for the giving me this opportunity to talk about this very interesting but like very basic but very interesting topic about digital subtraction angiography. So I thought multiple ways in which I should present it, but then I thought that no, rather than talking about just theoretical aspect, let me cover the basic clinical aspects and more from a working point of view, important things which we should all know about digital subtraction angiographies, especially someone who is starting new to this procedure. Okay, let me tell you about the basic or the first thing, a brief history about the digital subtraction angiography. We all know that in 1927, Moniz was the first person who introduced arterial encephalography. And that is the reason Indian Stroke Association has been working very hard to celebrate 100 years of cerebral angiogram in the year onwards. And we are planning to arrange 100 CMAs across the country. In 1953, that was the first time when Seldinger catheter technique was used, which was very helpful in arterial cannulation. And then 1963 was when Plantes introduced subtraction, followed by after 1980s, there was development of digital subtraction angiographies. And then since then, there has been a lot of advancement in the field of digital subtraction angiographies. There have been a lot of new techniques, new softwares which are available, which has made our life very easier. So if you look at the basic concept, it is a technology which uses something called as a digital subtraction to remove overlying bony structures and leaves only opacified vessels. When you inject a dye, which is an opaque medium, which opacifies the vessels, but by a technology you are able to remove overlying bony structure or whatever artifacts that you're able to see, then what you get is a very clear picture of the vessels, and that's what it is all about. And this technique allows for a high sensitivity in visualizing small vessels and any kind of vascular pathology. But the first question that comes to our mind always is why is it really so important? Why does it matter? So most importantly, it is the gold standard for imaging any kind of cerebral vasculature and diagnosing primary neurovascular diseases. It is a wonderful tool for temporal resolution diagnosis. It also helps us understanding the hemodynamics. Probably it is the only tool which we have available to understand the hemodynamics of cerebral vasculature. And it's very important if you're planning an intervention for any kind of neurovascular disease. And it is most commonly, it is the first step that we do before planning any kind of procedure. And mastery of diagnostic angiography is a prerequisite for neurointerventional training. So with this presentation, my objectives are that I'll be talking about what are the indications for cerebral DSA, what should we know about the procedural aspects, and what are the common pathologies that we usually encounter. So when you look at the clinical indications for DSA, first is there are primary intracranial neurovascular diseases like aneurysms. You can use it to evaluate the size, neck configuration, and relationship to the parent and adjacent vessels, which is very important if you're planning a particular kind of treatment modality. Again, it is very useful to diagnose arteriovenous malformations and fistula because it helps you in identifying the feeders, niders, and also the venous drainage pattern, which has a significant role in the treatment options. For acute ischemic stroke, it has revolutionized the treatment of stroke, and it is used to diagnose the site of occlusion if you're suspecting a stenosis, and to also assess the collateral flow, which also has implication even though you're planning a conservative medical management. And it is also important tool for diagnosing vasculopathy or in patients with subarachnoid hemorrhage if you want to diagnose vasospasm, if you have TCD available, if you are in diagnostic dilemma. When you look at the extracranial diseases to diagnose or to ascertain carotid and vertebral artery atherosclerotic diseases, if you are evaluating any kind of vessel dissection, carotid blowout, or neck trauma patients, it is again a wonderful tool. Patients who have epistaxis, in whom they are not being controlled by medical management, you can also do a cerebral DSA and treat endovascularly with these kind of patients. And then again, it is also helpful for surgical colleagues in which we can plan a DSA before the surgery and we can do a pre-surgical tumor embolization, which helps them in giving a blood-free field. There are also other indications that it also helps us in follow-up of the patients. So say if we have coiled a patient or if there's a patient who has a clipping of the aneurysm or stenting, we can do a follow-up cerebral DSA to assess the treatment success and also to assess the vessel patency. And also, if you're planning total parent vessel occlusion, you can do a VADA test and also do a functional testing to assess the what impact it would have on the patient. When you look at the contraindications, so practically there are no absolute contraindication for diagnostic neuroangiography. You always need to ascertain the risk-benefit analysis of the procedure. Yes, there are relative contraindications. So let's say if the patient has a severe contrast allergy, but if the benefit of doing cerebral DSA is higher and the risk is lower, then there are ways you can go around and do cerebral DSA. Patients in whom there is a renal insufficiency or chronic disease or renal failure, it is a relative contraindication. And patients, again, who have uncorrected coagulopathy, that's a relative contraindication. Now, when should we not do a DSA? So patients in whom the yield of getting additional information from the procedure is very low, when you do not expect a significant treatment change, even after you've done a DSA, probably DSA is not a good test to be done because it's an invasive procedure. Again, when you look at the risk-benefit analysis, if the risk of doing the procedure is far more than the benefit that you're trying to get, again, DSA is not a good tool because it's an invasive tool. So before doing a DSA, you should always ask yourself what difference your digital subtraction angiography is going to make in the treatment of the patient. Before we start the procedure, you need to understand the pre-procedural evaluation. First, you should be very good in taking history of the patient and a detailed neurological examination, because if you are not sure what you're trying to look, you'll never be able to find it. You need to ascertain the peripheral pulses, especially femoral dorsalis pedis, posterior tibialis, because that might save you from unexpected surprises when you're ready and about to puncture. And also you need to look at in detail about all the non-invasive imaging, whether it is a CT angio, MR angio, or any other modality that has been done, which might help you in planning, especially when you're trying to look at a particular type of catheter that you are going to use. In terms of laboratory workup, you should look at the renal function, because that is going to help you in counseling of the patient for the risk of contrast nephropathy. Coagulation profile, baseline hemoglobin to rule out acute, and also total leukocyte count to rule out acute infection, and also viral markers, which would be helpful for you to plan it in a proper way. Regarding the contrast agents, there are contrast agents available, but the most commonly used are the non-ionic low osmolarity agents like Omnipac. And the diagnostic concentration that is used is around 300 milligram per ml. But when you're planning a procedure, the concentration decreases to 240. But when you look at the total dose, it should not be more than 5 to 10 ml per kg of the body weight, because that is very important. That is going to cause a renal impact on the patient. When you look at your angiography suite or table setup, first, it should be sterile. The table should be behind the operator. It should be very clean because whatever that you're using, you are going to insert inside the patient and that can cause infections. The table should be long enough to keep your wires or catheters properly. You should always prepare a line, whether it's a diagnostic or a therapeutic. There should be heparinized saline. You should put 1,000 units of heparin in 1 liter of normal saline, which should be under pressure bags, and should be avoid of any kind of air bubbles, because air bubbles is a very important thing that you need to keep in mind. You should not inject air while you're injecting contrast. And ideally, you should have a biplane DSA, but it is not routinely available. But how advantage or what advantage does it give is that it helps you in taking multiple orthogonal views. It decreases your contrast dose and also decreases the radiation for the patient as well as for the treating physician. The patient positioning, patient should be lying supine with preferably with headrest. The arm should be lying at sides. If the patient is not cooperative, you can tie a headband so the patient does not move when you're injecting contrast, because it can give irritation, especially when you are going with ECA injections. Usually, if the cooperative patient, sedation is not used, only done under local anesthesia, but you can use midazolam or low dose of fentanyl. But make sure that you do not oversedate the patient, because that can help you in that can prevent you from diagnosing certain neurological diseases, especially if the patient is having obstructive sleep apnea and the patient is snoring. Patient might not be helping you with taking good proper images. Now, when you look at the workflow, the first thing that you need to take care is the access. Second is, how do you plan to catheterize different kinds of arteries? And then there are selective runs. So the most commonly vascular access that is used is the femoral artery. Right femoral artery, common femoral artery is the commonly used. There are two ways in which you can, sorry, I'll just use a pointer. Yeah. So there are two ways in which you can do a good femoral puncture. Is first, you might not use a fluoro. What you can do is you can put your left hand right from anterior supine, anterior superior iliac spine to anterior superior pubic tubercle, and then 3 finger below that you should put your right ring finger and palpate the artery. If you are able to feel the inguinal crease over there, that's where, like, if both the landmarks are matching, that's why you're planning to puncture. But if you're not sure about it, you can always use a fluoro. And your puncture site should be in the lower 1/3 of the femoral head and 1 centimeter medial. Because if you're puncturing above a bone, then it helps you in good compression and prevents any kind of complication related to the procedure. We all know about Seldinger technique. It is a single wall technique. How you do is you take a femoral needle, keep it at 45 degrees, you puncture the artery. The moment it enters the artery, you see a spurt of blood. The moment you see it, you can put a guide wire either with the sheath or a long 035 wire. Once it is inside the artery, you can always cross check using a fluoro. Once it is there inside the artery, you can take out your needle and put a catheter. Be very sure that once you're put inside your sheath, you need to flush, you need to give you a heparin. 3,000 units is the routine dose that is used for diagnostic procedures, and 5,000 if you're planning a therapeutic procedures. And make sure that you have a line which is using a pressure bag side by you. Can be also alternative access sites. A lot of people have started using radial artery because it gives it's very comfortable for the patient, especially patient can be ambulated earlier. But if you're not comfortable with the radial artery, you can always continue with your femoral access. How useful radial artery access site is that it eliminates the risk of retroperitoneal hemorrhage and also requirement for prolonged bed rest. When you look at the diagnostic catheter selection, there are different types of diagnostic catheter. Commonly used diagnostic catheters that are used are Picard. It's a 5 French catheter. You can also use a Wert or H1. It all depends on how comfortable are you with those catheters. When the arch is very tortuous, especially the type 3 aortic arches, you need to use a Simmons catheter. And then there's SIM1, SIM2, SIM3. And there are different ways in which you need to use it to cannulate different kinds of arteries. So depending on what your comfortable level is with different types of catheters, you can use multiple catheters to cannulate different types of arteries. But before you go into any particular artery, you need to understand what are you going to take as a projection. You should not be relying on your technician to know what kind of projection you need to take, you should be guiding your technician that this is what I want to do and this is what I'm trying to look at. So the common projection that I used are, first is anteroposterior, then you can have lateral, and then you can take obliques, whether it is 45-degree obliques on either sides or a 30-60-degree, depending on what you're trying to look. And then if you're able to find out a particular pathology, aneurysms, or heavy malformations, you need to take working views, because that would help you in planning the treatment modality. Now, when you look at the standard angiographic projections, the ideal or the first most important commonly used done is the posterior-anterior view, in which you need to superimpose your roof of orbit and the petrous ridge. That is the most commonly used projection. And again, it is a very good view for carotid injection. It gives you an overall information about the intracranial circulation. When you take a 25-degree caudal in which your petrous ridge is lying into lower one-third of the orbit, it helps you in giving more information about the carotid siphons. But when you go 30 to 40-degree cranial, or which is called as Townies, it is a very good view for when you're trying to look at the posterior circulation. You can also do further 45-degree caudal, in which it gives you a very good detailed information about the basilar artery and the posterior cerebral arteries. Then there is another submental vertex view, in which you can go further caudal angulation, which will be very useful if you're trying to look at the middle cerebral artery bifurcation, and also when you're trying to look at the anterior communicating artery pathologies. And then when you're trying to take a lateral view, make sure the floor of the right and left side of the anterior fossa directly overlap. Otherwise, you might see double images. Then there is another view which is called as Houghton's view. So when you're trying to look at carotid siphons, what you need to do is you need to ask the patient to tilt his head away from the site of injection. So if you're injecting on the right side, you need to ask the patient to turn his head towards the left side. It will help you in opening the carotid siphon and also in opening up of the MCA branches of the side which you are injecting. Now, before you inject the artery, you need to be very careful that you're not injecting any kind of bubble or clot when you're injecting, because if you do that, that would be an iatrogenic complication that you're creating. So you should always use a 10 ml syringe. If you're injecting into a smaller vessel, you can use a 3 ml or a smaller syringe, but with a Luer lock syringe. You need to hold the syringe vertically. If you look at this picture, you need to hold the syringe vertically so that all the air bubbles are lying at the top and you're not injecting any kind of air bubbles. You should never keep the syringe horizontally, because in that case, your air bubbles might be mixed with your contrast and that you might inject your air bubbles inside the artery. The typical volume of contrast that you should inject is around 4 to 6 ml of contrast saline mix, depending on the clarity of the pictures that you're getting. Once you have injected, you have used your wire to manipulate. You should manipulate into the particular artery. You should remember the double flush. So every time you take out a wire, you need to aspirate with a 10 ml of syringe. And then once you have removed it, you need to put again another syringe. You do need to do a partial aspiration. You need to tap it so that your air bubbles comes at the top and you're not injecting any kind of air bubble inside the cannulation in the artery. Before putting your catheters and wire, you need to be very careful that you should always keep your guide wire at least 5 centimeters ahead of your diagnostic catheter tip. Because if it is not that, you're actually creating a kind of sword kind of a thing. And once you're pushing your catheters and wire, you can inadvertently cause dissection, trauma, and iatrogenic complications. Now, once you're aware about what are the basic things you need to keep in mind, you need to know about how to navigate the vessels. So the usual protocol that is followed is that we start from the right side and finish at the left side. So right vertebral artery followed by right common carotid artery, ICA, external carotid artery, and then you come to on the left side and then finish with left vertebral artery. Although it is not compulsory that you should do it, if you're looking for a specific pathology, if you're doing a check angiogram of a particular vessel, you can directly go into that particular kind of vessel that you want to cannulate and look at. That is a technique that is recommended is that when you're trying to navigate your catheter, you need to rotate it counterclockwise, and then you need to pull it so that when it is coming from right side to left side, it jumps into the desired trunk. And then once you inject contrast, you can see the particular vessel and you can take your wires and catheters ahead. Road mapping is something which is very important. So just trying to play the video. Sorry, yeah. I'm sorry, this video is not playing. So one thing is very important is that you should have a roadmap or something called a smart mask in your machine. Without having a roadmap, you should not try to inject, or you should not be taking your wires and catheters into the cerebral blood vessels, unlike what the cardiologists usually do. Because if you are not taking proper roadmap, you might not be aware about the anatomy and you can cause injury to the patients. So this is something what a roadmap looks like. Once you are sure that this is the common carotid artery on the left side, you need to take your wire further, and then you can take your diagnostic catheter and then navigate. When you look at a normal cerebral DSA, there are three important phases. Usually, a standard DSA lasts for around 10 to 12 seconds, and it captures the complete transit of contrast throughout the brain. First phase is the arterial phase, in which you're able to see the major arteries and their branches. Second phase is the capillary phase, where you see a diffuse parenchymal blush, and with that, you can use it to identify areas of hypoperfusion or hyperperfusion. Last phase is a venous phase, which is very important if you are dealing with venous malformations or fistulas, or if you're trying to deal with any kind of venous abnormalities. The total amount of circulation time is calculated from the time the contrast reaches from the cavernous ICA to the first cortical vein. It is usually around 3.5 seconds, but should not be more than 7 seconds. If it is more than 7 seconds, you're dealing with something which is causing raised intracranial pressure. So if you look at this is a normal run. You see the arterial phase. This is the parenchymal blush, and then you see the venous anatomy. If you look at again, arterial phase, blush, and then you start seeing. So it is less than 3.5 seconds. So it's a normal run of the left internal carotid artery. But you need to be also aware about certain dynamic DSA findings. One thing is, if you're dealing especially with the posterior circulation, if you look at this particular run of the left vertebral artery, you might see certain lucent layers inside the basilar artery. This is not abnormal. What is happening is, when you're injecting from the left vertebral artery, you're seeing contrast, but there is also non-contrast blood which is coming from the right side, and you might see a lucent layer inside the basilar artery, which is only because of the non-contrast blood which is coming from the opposite side. But in other circulation, especially anterior circulation, you see certain kind of lucency. It might also indicate hemodynamic compromise or sometimes stenosis. Then, if you're seeing arteries displaced from their usual position, especially in the anterior in patients with the large hematomas or tumor, you might see that the vessels are displaced from their normal position. You can also find collateral flow. There are different types of collaterals. So let's say in this particular type of patient, the dye is injected into the left internal carotid artery. You do not only see the left MCA and anterior cerebral artery, but you're also seeing the right side anterior cerebral artery and the right side middle cerebral artery. This is all because of the collaterals, especially in this case, it is ACOM collateral. And then in patients who have aneurysms or dilated or dysplastic blood vessels, you can also see contrast clearing out slowly from the affected vessel, which is considered to be abnormal. Now, before you go into any particular type of vessels, sometimes you might have difficulty in hooking or going into particular vessels. So for that, what you can do is something called as aortogram. Aortogram, there are certain types of catheters in which is called as a pigtail catheter, in which you take your pigtail catheter into the arch, and then with the help of injector, you can inject contrast, and with that, you can locate all your blood vessels arising from the arch and might give you a good idea about how to go ahead. So once you are into the right side, so first run that you take is, this is what is right brachiocephalic artery, and you see two type of blood vessels over here. This is your right vertebral artery and then right common carotid artery. Once you go inside, it is always better that you take a lateral run. Depending if it is not visualized on lateral, you can take obliques or lateral, and then you can see your right internal carotid artery and the right external carotid artery. And then you can use your wire and catheter to cannulate any vessel that you want to study. Now, when you look at the IC anatomy, there are different classifications which are proposed. I'm not going into the detail of all the different kinds of classification, but there are certain important branches that you should know. So this is the lateral view of internal carotid artery. This is the anterior part. This is the posterior side. One of the important branches that you see is the posterior communicating artery. You can always diagnose it by the forking. So this is a posterior communicating artery. It divides into posterior cerebral arteries. Just superior or cranially to posterior communicating artery, you can see anterior caudal artery. Anteriorly, you might see ophthalmic artery. You might see this artery continuing and giving a blush in the orbit. And then very rarely you can see other smaller branches like infralateral trunk or mandibular artery or meningohypophyseal trunk, which might be not commonly seen in patients usually. Once your internal carotid artery reaches bifurcation area, it divides into two parts. This is your middle cerebral artery. When you further look at the middle cerebral artery branches, these are the lenticulostriate perforators, which are very important. And then after bifurcation, the moment it takes a turn into the insula, it divides into M2 and then further distal branches. So this is an AP view of the right ICA injection. This is a lateral view of the right ICA injection. If you look at this, so this is your internal carotid artery, divides into middle cerebral artery, and then bifurcates. These are the two divisions. Here is what you see as the anterior temporal artery. And then from the moment it kind of takes a turn upwards, you can label it as M2. There are different ways in which you can classify M1 bifurcation. But usually the moment it takes a turn upwards, it is called as M2, and then there are distal branches. When you look at the anterior cerebral artery, so this is your A1 segment, followed by anterior communicating artery segment, and then A2 and henceforth. This is the lateral view of internal carotid artery. Like I told you, the most important branch that we commonly see is the posterior communicating artery. And you can easily make it out by the forking when it divides into posterior cerebral arteries. And then obviously anteriorly, this is your ophthalmic artery, which is very important if you are trying to do any kind of procedures, especially in patients with pediatric patients with retinoblastoma. We are planning to do a tumor and a chemotherapeutic agent injection. When you look at the anterior cerebral artery anatomy, like we told you, this is the A1 ACA segment and then A2 ACA segments. When you look at the lateral view, this is the A1 ACA segments and then A2 segments, callosum marginal and different type of arteries. I'm not going into the detail of each artery. So once you have taken your internal carotid artery injection, you come to external carotid artery. This is a very this is not a very commonly done injection, but is a very helpful, and it is now very commonly used nowadays, because nowadays there are a lot of patients with subdural hemorrhage or ENT tumors, which we use it for procedures, whether it is a MMA embolization or a pre-surgical tumor embolization. So when you look at the anterior branches of external carotid artery, this is the lacrimal artery, superior thyroid artery, facial artery. This is again a distal view. So first, the posterior most branch is the occipital artery. Then this is the anterior part. It is your superficial. This stem continues into superficial temporal artery, and this is the anterior branch, which is called as the internal maxillary artery. And then this is your middle meningeal artery, which we commonly use for middle meningeal artery embolizations. Now, this is the right side vertebral injection. There are different segments of vertebral arteries. But if you look at the overall anatomy, this is the termination of right vertebral artery. Here you can see that there is a possible left vertebral artery also coming from here. Now, there are the few important arteries that we need to keep in mind. If you look at the lateral view, this is your pica or the posterior inferior cerebral artery. If you look at the anterior view, this is the posterior inferior cerebral artery. And then there are two side-by-side artery, which are your anterior and anteroinferior cerebral artery. These are the posterior cerebral arteries, right and left. And then these smaller branches are superior cerebral arteries. Many times one of the arteries may be absent, which might be taken over by different other arteries, and they form a different type of complexes, which is a normal variant seen in many kind of patients. Once you're done with the right side, now you come to the left side. So this is your left common carotid artery, left internal carotid artery. This is your left external carotid artery. And again, the similar kind of runs. This is your ICA, middle cerebral artery, going ahead with the distal branches. This is your anterior cerebral artery, and then further A1, A2, ACA, and A3 ACA segments. So let's say if you're trying to look for a particular pathology, what you can do is, rather than going for the zoomed out view, you can go further zoom in and then try to look at different pathologies. You can ask your technician to take different angles. So let's say if you're not able to look at bifurcation very clearly, you can ask the technician to rotate in either ways. You can take different kind of views in which you are able to look at the bifurcation. Many a times the anterior communicating artery is not usually visible. So you can, again, depending on the anatomy, you can take different turns, because this is a very common site for aneurysms in patients with subarachnoid hemorrhage. And you can take a zoomed in view and try to locate the different arteries. Again, this is the left vertebral artery, and then similar kind of views on the left side. When you look at the venous anatomy, this is the AP view. When you look at the late part of your cerebral angiogram, the venous part. When you look at the AP view, this is the superior sagittal sinus, followed by transverse sinus, extending into internal jugular vein. This is the lateral view of the same patient. This is superior sagittal sinus. This is the vein of Trollard, intercerebral vein. This is the straight sinus, and again, transverse sinus going ahead with internal jugular vein. Now, despite this 2D images, there is also something called as 3D rotational angiography. Now that is seen in most of the machines that we have across country. How it helps us is, it helps us in creating a rotatable, high resolution 3D workstation image. It is also very important for evaluating small aneurysms, which might be easily missed on routine runs that you take, different types of runs. But you need to, either you can take an hand injection, which has to be very forceful, or also you can take an injector by which you can take a 3-dimensional. So this is how it looks like. So it not only helps us in getting a very good image, it helps you in demarcating what are the arteries arising, what is the location of the associated branches. Yeah. So if you look at this particular aneurysm, so it not only helps us in locating the aneurysm, it also helps us in making a point that what are the blood vessels which are arising from the aneurysm, close to the aneurysm, which has a lot of treatment implication. Many times you do a CT angio or an MR angio, and then the radiologist tells you that this is an aneurysm, but actually it turns out to be an artery loop when you do a 3D rotation images. And when you do a CT angio, your radiologist might tell you, no, there is nothing except for the artery loop. But when you do a 3D, it turns out to be an aneurysm. So this is a very important tool. If you have this tool, it has a lot of treatment implication in any kind of patient. Now, after you have done, we also need to be aware about what are the complications of cerebral DSA. So the total major complication is around less than 10%, and neurological complication account for less than 1% among all the complication. And in patients who are elderly, more than 70 years of age, have a lot of atherosclerosis, especially smoker. If your procedure time is very long, more than an hour, or if there is history of recent ischemic events, these are the patients who tend to have more amount of complications. One of the major complications that you can have with your patient is cerebral ischemic events. But what one should be always aware that there is a known entity, something called as silent embolic infarcts, which you can see in almost 28 to 60% of the patient when you're doing a diagnostic angiogram. Many times you do a MRI next morning for whatever reasons that you want to do, but it turns out that there is a shower of emboli that you see on DWI. But most of those are silent events until there is a major iatrogenic event. There can be also rare neurological complications such as transient cortical blindness. It is often idiosyncratic and it is related to the blood-brain barrier compromise. There can be transient global amnesia, in which the patient can have an abrupt onset of symptoms in which there is complete forgetfulness, especially when you're injecting prolonged dye in posterior circulation. But in most of the patient, it recovers completely in 24 to 72 hours without any additional treatment. And very rarely, something dreadful that we always never want in our patient is when you're injecting contrast, there can be aneurysm re-rupture. It is seen in 3 to 5% of cases. I should not say that I've seen 2 patients in which I was injecting contrast in my patients and there was aneurysm rupture. So this is something that you don't want to have. When you look at the non-neurological complication, common complication includes groin hematoma around 10%. If the compression has not been adequate, very rarely there can be pseudoaneurysms or AV fistula formation. in which the patient might complain to you later after you've done cerebral angio and complain of local groin swelling or pain or pulsatile mass in his groin region. And then rarely anaphylaxis because of the contrast, and which can be recognized, but you should always have your anesthetic on standby. When you look at the radiation safety, you should always be very careful that you're exposing yourself as well as the patient to radiation when you're doing cerebral DSA. So you should try to keep your the radiation as low as possible. And that's where if you have a biplane machine available, it is very helpful. If you're dealing with the pediatric cases, grid removal can reduce the dose by almost 40%. If you're looking at a very close pathology, you should always try to collimate so that the amount of radiation decreases. You should not use a continuous fluoroscopy, better to use a pulsed fluoroscopy. And if you're not looking at any malformation, vascular malformation, try to keep your frame rate too low, at least 2 frames per second, because that decreases the radiation exposure. And then if you're the operator, because you're doing it regularly, make sure that you wear all the proper kits, which includes a proper lead apron, lead glasses, and also a neck collar. Talking about post-procedural care, you can achieve hemostasis either by manual compression, which is the most common used method in the diagnostic angiogram. But in therapeutic procedures, you can use a closure device. There are different types of closure devices which are available in the market. You should ask the patient to be immobilized for at least 6 hours once you have done a femoral artery puncture. And then side by side, you also need to make sure that patient's vital signs are monitored, because there can be local groin compromise along with regular neurological examination post-procedure. One other thing that you should always keep in mind is there is something called a series of unfortunate events, that whenever you're doing a therapeutic or a diagnostic event, if something goes wrong, usually it is the cascade of minor errors that we keep on, doing it one by one. So you can avoid any kind of disaster by recognizing what has been the wrong thing that has been done. And then you should have a very low threshold to stop. Whenever there is anything that you're not sure, you're not comfortable, try to stop. Should always have a plan B and C, whether it's a diagnostic procedure or a therapeutic procedure. And it is okay to pause. It is always better than rushing things and creating an unnecessary events which can be easily prevented. So just at the end, I would like to tell you what are the common DSA findings that we usually encounter. So first is, I'm sorry. Yeah. So first is stroke. So here you can see this is an intercerebral artery IC injection, and then there is a middle cerebral artery occlusion. Although there are leptomeningeal collateral which is coming from the anterior cerebral artery, but since this patient had an acute onset of symptom, you call it as an acute occlusion. Second is aneurysms in patients who have subarachnoid hemorrhage or who have mass effect symptoms. You can diagnose aneurysms. Cerebral DSA is the diagnostic modality of choice. It not only helps you in identifying the size, but also the neck, the dome, and also what are the branches which are incorporated. Like I told you, if you have a 3-dimensional imaging available, it gives you a very wonderful tool, and it has a treatment implication in which you can change the way you're planning to treat the patient if you have a 3-dimensional imaging available. Third is a lot of patients who have subarachnoid hemorrhage. You do a CT angio, MR angio, and then you do a DSA, but turns out to be negative. So in such kind of patient, you should have a very low threshold, and you should always repeat an angiogram. Like in this particular patient, which I had, he was a 67-year-old male, presented us with classical symptoms suggestive of subarachnoid hemorrhage. And when we did the first angiogram, there was nothing significant. And so that's why with a low threshold, we repeated an angiogram. If you see, there was a very tiny aneurysm that we were able to diagnose after when we repeated the angiogram after 1 week. And again, especially the 3D was very helpful in diagnosing this particular aneurysm. Another modality, another diagnostic point is the diagnosis of arteriovenous malformations. So this is an arteriovenous malformation, especially getting supply from the posterior cerebral arteries. So it tells you about what are the arteries which are feeding the vascular malformation, what is the nidus size, and what is the venous drainage, again, which has technical and treatment implications. Another etiology is the presence of dural AV fistula, which can present with different kind of symptoms. It So there is no particular nidus when you look at arteriovenous malformation, but there is a direct connection between the artery and the venous system. And then very important is something called as carotid webs. Now, with the increasing incidence of stroke in younger population, carotid webs have been diagnosed more and more often. Although you can diagnose them with CT angio, MR angio, or a very good ultrasound as well. But carotid webs, if you have a diagnostic DSA, it gives you a very good view and also tells you about what is the stasis of the contrast. So let's say this particular patient, we injected the contrast, and you can see even if whenever the venous phase is also appearing, there is still a contrast stasis, which gives you an indirect evidence that this might be the reason for recurrent embolic events. Very common etiology that comes to us in patients who had stroke in the past. CT angio or MR angio tells you that the patient has an ICU occlusion. So DSA not only helps you in confirming the occlusion, because many times you do not do a DSA and your complete occlusion in CT angio or MR angio might be a very critical stenosis, and which can be treated very easily with endovascular therapy. So DSA not only confirms your diagnosis, like in this particular case, this is an AP view. You cannot see the internal carotid artery. This is the lateral view, a very subtle view, but there is no distal flow. But it also helps us in assessment of collateral circulation. So in this particular case, even though the right ICA was completely occluded, but the patient was getting both right MCA and ACA collaterals getting supplied from the leptomeningeal collaterals from PCAs and ACOM and ACAs. And then very rarely you can also have an uncommon situation. So this is one of the patients that I had. So just I'll finish with this last case. So he was a young guy, presented to another neurologist with recurrent episodes of stroke. All of the stroke in posterior circulation, despite being on optical medical management, like multiple episodes over many years. And he came to us in 2024. So when we did the MRI, there was no fresh stroke, but luckily the radiologist was smart enough or sharp enough to note that there was an increased atlanto-dense distance. And also we did an NCCT CV junction, which showed increased atlantoaxial distance, and along with other findings. So that's where we thought that this could be a case of dynamic compression of the posterior circulation. So we thought we'll do a DSA. So this is the first run of ICA, nothing significant. Then this is the right vertebral artery. This is in neutral position. We didn't find anything concerning over here. And then I also thought that I would do both vertebral injections, and it will be a dynamic. I'll ask the patient to change his position in either left lateral and right lateral, and let us see what happens. So if you look at this, so this is the neutral position, right vertebral run, nothing significant. When I ask the patient to turn on the left side, again, right vertebral, nothing significant. And this is the right lateral position. So no compromise. So I was pretty happy with that. There is nothing significant. This is a left ICA, looks okay. And then this was the left vertebral artery, intracranial runs, nothing abnormal with the origin. This looks okay, no significant hemodynamic compromise in the routine runs. But when I took multiple runs, so this was the neutral run of the left vertebral artery, nothing significant. The moment I asked him to turn to left side, okay, so nothing on the left lateral position. But the moment I asked him to turn on the right side, you can see that it is almost getting occluded because of the compression from the cervical vertebrae. And this is the lateral view. There's a significant hemodynamic compression. So that's where we diagnosed that the patient was getting recurrent attacks depending because of the compression of the left vertebral artery. And then after catching my breath, I repeated it again. So this was a neutral position, nothing abnormal. But the moment the patient was taking a tilt towards the right side, the left vertebral artery was getting significant compromise. And then the moment he was taking turns on the neutral position, it was becoming normal. So this is what we diagnose as a case of Bow-Hunter syndrome, where there is a dynamic compression of vertebral artery because of instability. So if I have to conclude, DSA is safest when it is practiced in a methodical, repetitive, and consistent manner. Making a protocol always helps. You should have a good anatomy knowledge, whether it is a normal anatomy or a variant or abnormal is crucial. You should never perform a cerebral angiogram under rushed circumstances. You should always, take things very slow. And the priority in the room is always patient safety. And you should never hesitate to ask, give a call to your seniors and ask whenever in doubt. Thank you so much for all your attention. I would be more than happy to take any questions. Thank you so much.
Nice presentation, Piyush. So there are no questions as yet in the QA section, but yeah, so now we have a question.
Okay. So book for anatomy, there are book for cerebral DSA. There are a lot of good books. You can have Harrigan, Morris, which you can use to look at the normal anatomy and also the normal variants and abnormal pathologies. There are a lot of good books available. If somebody wants to have it, I would be more than happy to give it to anyone personally.
So
Hello.
yeah,
Sir, there is a question in chat box. Can you check this
Yeah.
question?
Okay. So we've discussed about books. Vikram sir, shall I answer?
yeah, sure. Please go ahead.
Thank you. Okay. Uh, okay. So Morris, Harrigan, these are all good books. I can give mail ID more than no problem. Or if somebody gets stroke during a diagnostic DSA, how to proceed? Okay. So first thing that you make sure is what has happened, whether you've caused any dissection, whether there is any trauma, or whether you have whether there was a floating clot which has actually gone to intracranial circulation when you injected contrast. So if it is just a clot which has gone to the intracranial circulation, you need to take your stent retrievers and aspiration and take it out. If it is a very small branch, probably you don't have to do anything. You also need to look at whether it is supplying any eloquent area or not. But if by any chance you have caused dissection, then you need to consider whether it is really compromising hemodynamically or not. If it is not causing any significant hemodynamic compromise, you can consider waiting as well. You can give patient anticoagulation and observe for a good amount of time. But if there has been nitrogenic dissection, it is causing significant hemodynamic compromise, you need to consider putting a stent. So because if you do not do that, it would continue to increase. But you need to make sure whether the patient is really on any kind of antiplatelets or not. And that is another important thing. If you're planning to do a diagnostic DSA and by any rare chance that there is a possibility that you might have to put stent, you need to always make sure what kind of antiplatelet therapy the patient was taking prior to that. I can write my mail ID over here.
So I'll just read the question, and there is a question regarding protocol of spinal DSA. So I believe we have a dedicated session
Yes.
for spinal DSA.
Yes.
So it will be taken at that time. Next question is timing of diagnostic DSA after a stroke with IC stenosis on MR angiogram.
Okay. So
So
if the
do you
patient,
want to
if the
answer?
patient, yeah, but sir, please go ahead, sir. So
No, you answer. Not an issue.
okay. So usually if it's only a diagnostic thing that you're trying to ascertain, uh, usually in the immediate acute phase, it is advisable that you should not do because there could be a lot of the hemodynamic factors which might be playing a role. There could be an unstable plaque over there. But like I told you in the earlier slides that if before doing the DSA, you should always ask yourself, what are we trying to do or what is the treatment implication that we are trying to look at? If the patient is having recurrent strokes and then CT angio or MR angio tells you that there is an occlusion, there is no significant changes on MR DWI, I think it is better to do a DSA early because if it's a critical stenosis, there can be a treatment change that you can offer. But if there is a major stroke, and then even if you do a diagnostic DSA early and you're not going to change any medical or any therapeutic change immediately, maybe you can wait for at least 48 to 72 hours and then go ahead with your cerebral DSA.
The last question is role of tirofiban infusion during thrombectomy procedure.
Okay. Okay. So there are a lot of upcoming theories which are coming about it. So as of now, I personally do not use tirofiban infusion after thrombectomy. So there are a lot of studies which have actually come up in which people are using tirofiban, especially if there has been showering of emboli after you've done mechanical thrombectomy. But still, I think we should wait for the final results to come.
Hello. Dr. Vikram?
Yeah, please tell.
Sir, has every question is taken up or we can?
Yeah, all questions have been taken up.
Oh, sure.
There is one more question now. So these questions are all related to stroke thrombectomy. I believe the next session is about stroke only.
Yes, sir.
So I think it will be better answered that time. Piyush, do you want to answer chances of early neurological deterioration following thrombectomy?
So early neurological deterioration following thrombectomy, it all depends on what is the pathophysiology you're looking at. So if you have had a successful recanalization and there is an early neurological deterioration, you need to make sure that that there is no reperfusion bleed that has happened. If the patient has had received IV thrombolysis, if the blood pressure was not monitored properly, there could be an intracerebral hemorrhage. So usually, if there are no untoward incidents that you have observed during IV thrombolysis or mechanical thrombectomy, and it has been a successful procedure, the chances of early neurological deterioration is pretty low. Usually, there is a reason, why patients deteriorate, even if it is a futile recanalization or a reperfusion bleed, or there is a procedural issue, or the blood pressure monitoring has not been adequate. Then only patients do have an early neurological deterioration. Usually, they don't.
Dr. Vikram, can we give the closing remarks?
Yeah. So thank you, Dr. Piyush, for your comprehensive and very detailed presentation about the procedure of DSA and all the reading of DSA images. So with this, we come to the end of our first presentation, and it will be a great pleasure to see you all again after 2 weeks. Thank you.
Thank
Good
you, sir.
night.
Thank you so much. Thank you.
Thank
Good
you.
night.
Good night.
Thank you, everyone. Bye.